orthotics, and a lot of discussion around what the guideline says, why, which are fantastic things. So today, we're going to limit this discussion to the foot alone today, and we'll be looking at it from vascular point of view, like I said. So if we look at the foot, so generally, we can all appreciate that the first contact with the floor is our foot. And aside from that, the foot does a lot of things when it comes to, shock absorbent, shock absorbing. And when it's also a point of, it's also our rigid contact when it comes to propelling our body and all of those things. And since every one of us has started working maybe around 8 months, 8 months, 11 months, depending on your developmental milestone. Of course, our foot is going to still remain our engine, if God wishes, which we pray till the end of our life. So we need to think about taking good care about this foot. Either you are diabetes or you are non-diabetes, our foot must really, really be well taken care of. So these are stuff we need to be discussing today. And before I go to the next slide, I would also like to say this, that from physio point of view, this is also one domain again that we also need to also reinforce. Like when it comes to this health discussion or health outreach that we conduct a lot. I think it's also one area. Just like the way we take back pain, we do health education for people on those things. We also need to also reinforce these things to the public, that taking good care of the foot, it really, really goes a long way in their health. Because in my practice, I have met a lot of patients with infections in the foot. From there, some people might come down with renal issues, some people heart issues from infections, from a whole lot of things. So taking real good care of the foot is really very important. And again, so let's get started. The foot, we all know the anatomy of the foot. We are not here to discuss anatomy. I won't go into details of that. Or these things I can just say is there I think around 26 bones in the foot, and the joints are maybe around 33 or thereabout, and you've got a whole lot of muscles, ligaments. I think something close to 100 or above 100 when it comes to the muscles and ligaments, the other soft tissue that you've got in the foot. If I go to the next slide, so when it comes to the causes of minor amputations, we are looking at things like diabetes. It could be either metabolic, anything metabolic. It can make somebody to lose any part of their toes or any part of their foot. It could be vascular related. It could be maybe arterial disease or anything, claudication, poor blood supply. So all of those things related. And again, from yesterday when I was talking about the issue of major amputation, specifically below knee amputation, I think I mentioned that one of the greatest risk factors to below knee amputation is somebody have got ulcers, you've got wound in your heel. If good care is not taken, the heel might likely deteriorate, and that person might likely lose their leg for that. So we really need to think about these things, have a whole lot of discussions, look at the wound, how do we do assessments, what foot device will be more appropriate to that patient to offload that particular area. So we're going to be discussing some of those things. So in terms of assessment, how do we assess the foot? So generally, physio-wise, so you are looking at 3 different domains. You are looking at the vascular domains, you are looking at your MSK, and you are looking at your neurology. And in terms of MSK, you are looking at the shape of the foot, what is the alignment, how does the foot look like, all those kind of things. You are looking at, have they got any deformity, have they got charcoal foot, have they got any Hodis, equinus, or it could be congenital related, it could be acquired, it could be anything. You are looking at that foot alignment when they are sitting down. Do that in different fundamental positions. If they are sitting down, get them to sit, get them to stand, get them to walk, observe, what can you see, all those kind of things. Then again, MSK is also involved in checking their nails, the foot nails, look at the skin. Is there any skin breakdown? Is it dry? Is it wet? Is there any skin breakdown? Have they got any wound anywhere? Try to observe. Is there any ulcer? Where is the ulcer? Where is the location? Pay good attention to it. In terms of, again, in terms of footwear, again, we also need to look at what footwear do they like come to our clinic with, or if you are seeing them in the hospital, ask them what footwear, even if they are in bed, what footwear have they got? And again, in terms of again, we can also think, because we deal with AD health of patients, we can also ask them indoors activities, what kind of footwear do they normally use at home? If they are going for outdoors activities, or they are going for one bed, they are going for to churches or to church, or they are going to mosque, what kind of footwear? So we need to check some of those things. And again, this thing is not just physio alone. These are areas where we need to be working with different specialties, especially the orthotics or the podiatry. We need them. We need to be working with them here. So in terms of your vascular, what are you checking in vascular? You are checking in terms of their circulations. You are checking at the foot. You are inspecting the foot. What is the color? You are looking at things like, if you palpate their foot, you are looking at you can palpate their dorsalis pedis arteries, posterior tibial artery. You can, I think there is this thing they call 5Ps as well, on like the pain, the paresthesia, the pulse, the if there is pulselessness, if there is which other thing, pale. So look at those 5Ps. These are things you will find under the vascular, which is the circulations as well. So, and again, the other thing here is all about, and aside from that, you can also look into the the sensation part of it, the neuro part of it. That sensation might come in maybe three things. You are looking like at the sensory aspect of it, the light touch, the temperature, the pain. You are also looking at the motor neuro now. You are looking at the motor aspect of it, the strength in the intrinsic muscles, what strength have they got? Because if they've lost I've seen patients before with a very like atrophies of those the foot, the muscles of the foot. So because of the poor vascular supply to that leg, so the muscles start improvising and all of those things. So look into that, do your strength testing, do your range of motion testing. Aside from that, what other thing are you checking? You're also looking even the autonomic part of it, like the autonomic aspect of it. Ask them those questions, like in terms of sweating, in terms can they feel things, in terms of because sometimes there are some patients that will tell you, maybe even you find this in often sometimes in stroke patients, maybe some part of their body can just be more sweaty than the other part of the body for so for reasons they can't just explain. Things like this, you want to also ask them if there is any anything like that. So so just break it down into three. This other slide here is just breaking that down into three parts again, like the vascular aspect of it, like what I just explained. And again, from the vascular aspect of it, I didn't mention that in the last slide, is let's say for instance, you prepare for the pulse is not, it's not great, the rhythm is not there, you can't really feel it, it's difficult. And again, sometimes it could be very difficult. It could be maybe the limbs is swollen, something like that. So the arteries is not really very palpable. So and again, it could, aside from being swelling, aside from the swelling, it could also be maybe the potency of that artery is not there anymore. Then we can then begin to look into, can we explore more and other diagnostic tools like the Doppler ultrasound or something, or even ankle breaker pressure index is something we can also do, or MDT can do. And again, like I mentioned, this is going to be MDT kind of things. It's not just physios. You need your nurses. Even when it comes to domains of nurses, you can find vascular nurses, district nurses. You can find stoma, what do you call them again? Vascular nurses, district nurses. You can find, there are different specialties of nurses, even in these things as well. So even diabetes nurses, they are very relevant here. We need to be working with them. So of course, your orthotics, you are working with them. Your podiatrists, you are working with them. Your vascular doctors, dermatologists, you are working with them. Tissue fiability nurses as well. They are different. We've got different specialties of nurses, even in this thing. So it's not just physio, but we can also add our home beat when it comes to having a good clinical reasonings, look at your patient. What are you worried about anything? If you are worried about anything, use the MDT around you. Who do you want to speak with? Do you want to speak with the doctor? Do you want to liaise with the nursing staff? Do you need the dermatologist if you are worried about anything, about their skin? Do you want to speak with the podiatrist? All of these things is not because it's really, really a whole domain, honestly. Vascular on its own is really, really a very, very big domain. So we are not in this thing alone. It's normal if you go to the patient bedside and you are very worried about their wound and you don't really know what to do, honestly speaking, completely normal. So rather than not doing anything, try to use the power of MDT you've got, speak to the doctor, get their own opinion, speak with the authorities, get their own opinion about it, and from there we can begin to see what we can do for our patients, if that makes sense. Sorry, are we there? Can we hear me? See flowing?
Yes, sir.
Hello?
We can. We can. Right
All
on.
right. All right. Thank you. Thank you. So the consideration for the footwear, considerations, generally speaking, and again, let me say this because I'm likely to forget. So when we talk about footwear, oftentimes everybody, not just physio, everybody, MDT wise, like doctors, nurses, everybody, we often forget that it is not just limited to people that are walking alone. Like when we talk about foot generally, we are not just concerned about patients that are mobilizing or clients that are moving around. We are also concerned about people that are bedbound, people that are not moving around. We should also be concerned about people that are wheelchair bound. Because if you are wheelchair bound, it could also mean that maybe you've not got sensations in your leg, or you've not got or maybe you've got you can also have vascular issues, you can also have diabetes, you can also have anything. And aside from that, it could even be maybe you've got your patient have got neuro condition, maybe stroke, they are not bedbound, they are not moving around. Yeah, we should also be concerned about their foot. This is foot health. We should also be concerned about their foot. Why? Because if that foot, don't forget the heel, they are likely to, the skin is also likely to break down, like skin damage, like pressure damage, just like you can have pressure damage in their sacrum, in their bum, you can have it, anywhere. So the heel is also a pressure area. So we also need, if they are in bed, they are not moving around, they are always in bed. We also need to be worried about, do they need any offloading in the bed? What can we give to them? Or what are the things, how can we help them to offload some pressure area so that area will not start breaking down? I have also seen patients again with pressure damage. These are with a neuro background. They've got stroke. They are not mobilizing out of bed. They are not getting out of bed, but they now have a very, very big pressure damage to their heel. And again, because of their poor background, in the long run, they need to amputate the leg. They need to get rid of the leg. They need to chop their leg, just because of something that I know it's difficult when it comes to bedbound patients that are okay in bed, like helping them to offload pressure area is always very difficult. But oftentimes we pay attention to the bum, we pay attention to other area, but we oftentimes ignore the heels, we ignore their leg, their foot completely. So it's also something that we also need to start taking into consideration as well. So, and when it comes to offloading, generally we need to think about mechanical load. This is our domain, this is our bread and butter, this is our area. Now look into the mechanical load and biomechanics. Like, you don't want to overload any areas of the body, any areas of that foot. You don't want to overload it. You want pressures to be evenly distributed. You don't want to overload the bone, the intrinsic muscles. Remember I mentioned earlier that we've got, I think, about 26 bones. So remember, so now if you've got about 26 bones, so how can we now equally shift the pressure so that one areas will not be more prone to pressure than some other area? This is why we need other people in the MDT to also use them to achieve what we need for that particular patient. So all right, so load distribution is also very important, load sharing and all of those things. They're also very important when it comes to, if you are looking at your patient foods and you are now thinking what you want to make decisions for appropriate footwear for them. So you need to be thinking about all of these things. So if I show you this picture, if I show you this picture of this patient, suppose this is your patient. From physio point of view, first of all, if you have a look at this picture, so what can we say about this picture? Look at it. Look at the foot. Where do you think is the pressure area? What do you think is going on? What can you say about the toe? What can you say about the alignment? From physio point of view, what in the long run, what do we think is likely to happen to this patient if care is not taken? And again, what do we think we can do from physio point of view? Is there any referral you are thinking about? Is there anyone you are thinking you like to work with in this patient group? Yeah, can I get us to have our to share our opinion on this?
Hello, sir.
Yeah, hello. Thank you. Yeah.
Okay, well done, sir. Okay. I'm looking at the patient. It's the foot. It's like it's a flat foot, pes planus. It's like the patient doesn't have this arcs of the foot. That's what I can see.
Oh, all right. Brilliant stuff. Yeah, thank you very much for that. Yeah. So is there anything, are we worried? Yeah.
I would refer them to the orthopedic surgeons, I think.
Okay.
Yes, I think I work with the orthopedic surgeons.
Okay. Yeah. Thank you very much. Good stuff. Thank you. Yeah. Being able to identify that, I think something is wrong here. Yeah, I think I need somebody. I need second opinion. I need somebody to bring their clinical reasoning to the table. It's also very important. Thank you for that. Absolutely good one. Thank you. Yeah. Pretty messy. Yeah, your hands is up. You can open your mic.
Yes, sir. Okay, so I noticed that there's also swelling at the ankle. That's the medial malleolus, the region there that's on the right side of the leg. Like is much more swollen, like it's more noticeable than the left foot. So that will like affect the biomechanics of the foot. So in that case, as a physio, I can address the first line of treatment should be to reduce the swelling in this case.
Okay. And what are we looking at, like in terms of treatment? Is there anything we want to be doing for them or?
Okay, yes, like cryotherapy. Yes.
Okay, thank you very much. Good stuff. Brilliant stuff. Yeah, she mentioned if you look at the heels, you can see that seems to be like a swelling. Yeah, that's good observations. Of course, that's one of our greatest skills as physio, being able to identify, look at things. Yeah. But yeah, the cryo could also potentially could be a line of management. But what I would say is sometimes in some of these patients, we also want to rule out, what is the cause? Look into their past medical histories, like vascular related. If it is, like arterial disease or something like that, we want to take caution in some of our modalities. And of course, it could be maybe this is a congenital case and they've not really got that past medical history. Cryo, they got swelling, let's do something. Yeah, good stuff. Appreciate that. Thank you for your observation. Yeah, PT Sonny, yeah, your hands is up. Your hands is up.
Good morning, good afternoon, sir.
Hello.
Yes,
hello.
Sir. Hello, sir.
Hello. Can you hear me, sir?
Yes, audibly well, sir.
All right. Thank you so very much, sir. Yeah. Some of my colleagues have spoken very well concerning the condition before us now. Now, if I am to be the one managing based on what we are seeing now, yes, obviously, there is
I think it's like every
swelling.
weekend.
There is swelling of the feet there, very obvious. And we could also see that the medial malleolus, there the protrusion around that area. So the even in addition to other treatment, this thing which I may give, some of which they already mentioned, first thing I will do is to liaise with P&O to get a very good footwear.
Yeah.
A very good footwear with a medial raise, an insole that will help to lift up that medial aspect of the foot, a kind of giving us that the what's it called, the arc to support or reinforce the medial arc of the foot.
Yeah,
I think that's the first area I will look at. And if that footwear is in place, then I can start with other exercises to help strengthen the muscles that will keep that arc in place. Then I work on other areas too. That's what I will do first. Thank you, sir.
Perfect, brilliant stuff. Thank you very much, PT. I'm very happy with that. Thank you very much. Thank you very much. I'd like to get maybe one or two more opinion. Just here to share our knowledge. Two more opinions. Suppose this is our patient. Who are we worried about? Good afternoon, sir. You're welcome, sir.
All right. Thank you so much so far. So, looking at this patient presently, what I would like to see at first, I think I would like to see a radiological investigation, preferably an X-ray, to see the joint alignment, especially between the medial malleolus, the talus, and the heel bone, to see what is actually going on in that area. Okay, and based on that, I would also like to check the range of motion. This patient's foot seems to be in over everted. Okay, so there may be there may be a loss in the range of motion of the eversion. And also looking at the patient, try to see whether through passive range of motion, whether the patient can still go into inversion and eversion. Then we would like to see from there we can see whether maybe a surgical correction may be needed to bring the joint back into alignment, or if it's something that is
Thank you very much. Thank you very much. That's a very, very brilliant contribution. Of course, this is just clinical reasoning kind of things. There's no direct way, there's no yes or no, there's no right or anything. It's just what can we see, what can we observe? And again, imagine if anything is not being done, if maybe physio is the first contact in this patient, if we didn't get things right for this patient, of course, even mechanically, we can relate what is likely to happen in the long run for this patient. You can relate abnormal alignment, even in the hip, in the knee, and all of other places, like in the chain of the joint upward. You can relate that. So, and again, we can relate to the pressure area. If we look at the pressure area here, at this side, at the medial side, bilateral, we can relate what could likely happen in the long run. Just like the last PT mentioned, you can relate potentially, maybe case of fracture. No, you can anything here, we can relate. So these are all very brilliant contributions. So we'll come back to these things to talk about some of the management we can explore for this kind of patient, but let's crack on for now. So, all right, thank you very much. I really appreciate that conversation. So the other thing here is about risk stratifications. I won't go in detail of this because majority of things here are much more obtainable here. But I'm gonna leave. By the time I send this slide over, I will leave it so we can read through to see, yeah, if we see this, if you are doing this assessment, that 5-point contact I mentioned the other time, is actually used to design these risk stratifications here. But I won't sit down with this and start analyzing this. But what I would just say is, in whole, the summary of this risk stratification here is just food needs to be taken serious. Just like we take every other part of the body serious, we need to be taking the food serious. We need to be checking either the patient is bedbound, either they are mobilizing, or either they've come with, even if they've come with back pain, like our outpatient day, if your patient is have come to back pain, they've got stroke, they've got anything, we also need to be assessing holistically. Look at their food, not just the upper body, the strength in the leg or anything. We also need to be observing for their leg and provide education, appropriate education for them. So, all right. So in terms of diabetes foot lesions, diabetes foot ulcer, I'd like to quickly talk about these classifications here. This is Wagner classification. So as physio, I will advise that it's something we also need to be very, very familiar with. So we need to try to understand some basics about this. This will also guide when it comes to ulcer, wound ulcers, when it comes to foot ulcers or wound or gangrene or anything. So this might help us to quickly identify some things and quickly make some decisions. So this is a scale of 0 to 5. So grade 0 is just there is no wound yet, there is no ulcer, there is nothing else. Of course, their foot will look nice, but there are concerns with, there are some vascular concerns. Like these are people that might be complaining to you that they've got sensory loss in their foot. They might complain that maybe sometimes their foot can be numb, sometimes their foot can be they can have some sensory imbalance in their foot, something like that. Yeah, that these are people with grade 0 sometimes. So what do we want to do physio-wise with this kind of people, with this kind of patient group? Oh yeah, we want to advise them about foot education. Taking good care of their foot is really, really very important. And again, foot inspections is also something we want to be telling our patients. They need to be observing their foot. They can sit in front of the mirror, sit down, use the mirror to get the feedback and like to use the mirror to observe their foot. Or it's something, yeah, we live a communal life in Nigeria. It's something their child or their wife or husband can be checking for them, just to observe to see if there is any skin damage or breakage or anything that is going on in their foot. Because oftentimes people don't just give it, they don't, even sensory changes, for instance, people just, most of the time, if it's not painful or anything, people just tend to ignore, they don't even take it serious or anything. But this could actually be me, sometimes it could mean some pointer, it could mean maybe diabetes, it could mean maybe they need some glycemic control or anything. So that's just grade 0. So we need to start taking cautions, pay attention to certain things and providing educations around footwears, educations around inspections of their foot regularly. Then if you look into grade 1 is just the superficial part, just the skin that is skin breakage, that is something like a wound now, but it's still just superficial. So what do you want to do about grade 1 from physio wise? Then now we need to start looking at, how do we protect their foot now? Grade 0 now is now different from grade 1. But grade 1 now, there is a localized wound now. If care is not taken, that localized wound can get deteriorated and enter into the grade 5. So grade 1, what do we want to do? Yeah, we want to observe the wound. Is it dry? Is it wound? Is it dry? Is it dry? Is it wet or something? If it is dry, sometimes you might want to think about it. Yeah, they can still be using their own footwear. But in that regard, their own footwear, like walking barefooted, might not be an option for this kind of patient in this regard. You might want to provide some education about if they need to walk around, they need to get something to provide cushions for their leg. It could be their own footwear or anything. It could be, again, we may need to work with orthotics, and providing some medications around in terms of padding of the foot, or in terms of padding of their footwear, anything, if there is anything that they need around that. Because if care is not taken, they will start breaking down. But again, if it is wet, let's say it's still superficial, but it's wet or something, it could also mean maybe might need to start looking at an offloading footwear for them, maybe just to provide an appropriate healing so that appropriate healings can start happening. We might start thinking in that lane. If you look into grade 2 again, grade 2 is now, it's more deeper than grade 1. Grade 2 is just like now, it is more like you have gone deeper to the dermal region, like the ligaments, the tendons, and everything. The ligaments, the tendons, and everything are now being involved in these things. Let me repeat, grade 0 is just superficial. Grade 1 is just the skin area, the superficial skin. Grade 2 has gone deeper a bit. Now there is now involvement of the ligament, of the tendon, and everything. So what do we want to do here? Of course, other line of management, medications, wound care. Of course, they need nurses here. They need the medical team to control their diabetes or anything. So they also need us as physio. Start thinking about an appropriate footwear for this patient group. So, so we are thinking about an appropriate offloading boot here. So we really need to start thinking about offloading this region for this patient. We need to offload this region. We need to provide an appropriate offloading boot for this patient. So the offloading boot, what the role of that offloading boot is just to shift pressure. By the time they stand on their leg, it's just to shift pressure away from that localized region. It could be anywhere. It could be in the heel. It could be anywhere in their foot, in the plantar surface, any weight bearing surface. So we need to start thinking about that for them. And grade 3 is just now, this thing has gone beyond expected. The bone is now being affected. It could be maybe now they've got osteomyelitis on top of these things. Infection is there. Pus is now coming out of these things. So again, this is much more higher. Bone is being affected. If bone is being affected, what that means is if they just ignore, they keep working on their leg, there's potential fracture. Don't forget osteomyelitis will further make the bone much more weaker. There's a risk of fracture and everything. Before you know, the wound will now start getting worse and worse. And yeah. So so grade 3 again, you are still looking at, yeah, the medical team are doing their bit. Physios, we are also thinking about providing educations, providing footwear. They still need an offloading. So grade 4. So in terms of grade 4 is now gangrene. It's just the foot is now gangrenous now. The blood supply is not great again. Everything is now the bone ligament. Everything is now spreading around. That's grade 4. And grade 5 is now like an extensive gangrene, something like that. So, but what we really have to remember, we might not really have to, we don't have to cram anything or something. What we just need to remember is, let me just admit these people first. Sorry. So what we need to remember here is, let's make it clinical now. If I go to the patient bedside, my responsibility, especially if you are on vascular ward, if you are on vascular ward, like diabetic endocrinology ward, diabetics, like diabetic related kind of things, you need to be checking your patient's foot. Don't just go there and start exercising patient, getting them up and start moving them. No, you have to be observing their foot. You need to be looking at their foot. Now, let's say for instance, now I go to my patient bedside, I inspect their foot, and I'm seeing something like maybe wounds in their foot. I need to sit down now and have a think. Does this thing merit an offloading boot? Do they need to continue using their own footwear? Do I need to educate them that enough of walking barefooted? Do I need to educate them about now they need to start taking caution? But what is because the risk because if that wound continues to get worse and worse, what is the risk? The risk is for that is they might likely lose the whole leg. They might likely lose the whole foot. So we need to start thinking along this line. So if I want to really ask one question here, of course, this is a clinical classification kind of thing. But suppose this patient has been put down, any of these grades now, suppose that we've got patients we've got grade 1 patient on the ward, we've got patient with grade 0 on the ward, we've got patient with grade 3, grade 4, grade 5 on the ward. So if I run an X-ray of those patients, when is it likely that the X-ray is like at what stage grade do you think X-ray is likely to pick something? Because these are oftentimes when you go to see patients on vascular ward, endocrinology, or whatever ward. By the time, of course, they are likely to have done X-ray, or maybe the doctor have requested for X-ray. By the time you check the X-ray, at what point do you think X-ray is likely to pick up something?
Grade 3.
At grade 3.
At
grade 3.
Okay, yeah. Why is there any reason for that so that we can learn?
Okay, I'm thinking because with the bone involvement, it will show on the bone.
Yeah.
The bone will not have the correct outline, how it's supposed to be on a normal X-ray.
Perfect. Brilliant. Brilliant. Thank you very much for that. Because why I ask that question is this. Somebody may be in grade 2 and they have done X-ray. Because sometimes if somebody is not very careful, you can actually get the clinical reasoning wrong. You can make the wrong decision for your patient. You can think, oh yeah, they've done the X-ray. There is nothing. The X-ray does not show anything. X-ray is fine. But they've got grade 2. And grade 2 might not likely show anything on the X-ray because it's still just tendon. Of course, X-ray is not going to show your soft tissue. It's not going to show your muscle, ligament, and something. It's not going to show those things. So yeah, you might feel like, yeah, they've done X-ray. X-ray is fine. So keep doing. You might not even tell them anything. Might just say, yeah, keep working, keep doing your stuff. Before you know, in the next 3, 4, 5, 6 months, you have entered into grade 5. What happened? Poor clinical information to the patient.
You would have just gone inside the house and greeted the in-laws.
Poor clinical information to your patient. That is it. So now, so thank you for that response. So when you do X-ray, when you run X-ray on this kind of patient, X-ray might likely to start showing something like bony concern, or cortical issues, peritoneal, this thing on your X-ray. Maybe around grade 3, because bone has now started getting it. So we need to understand that. So if somebody is now grade 2 and X-ray is not showing anything, that does not mean that this wound is not there. That does not mean that infection is not there. That does not mean that blood supply is still not going. It's not that blood supply is great at that moment. So we need to that X-ray does not still change your line of management. That's the point I'm trying to make. And what are your likely line of management in this kind of patient? You are providing education to them. You are referring them to podiatrists or orthotics or whoever is in your hospital where you work. You are thinking about that for them, if that makes sense. All right, let's crack on. Let me quickly read the chat box. Voice, please mute everybody. Can we mute our mic, please? Can we mute our mic? Let me get feedback, please. Is it making sense? Are we getting these things or no? Hello?
It's making sense. We are following.
All right. Thank you very much. Yeah. So let's talk about, let me talk about this thing. Before I go to that next slide, I forgot something here. So if I may ask us again, at grade 4 and grade 5, from physio point of view, what advice? Suppose you've got patient on the ward now, they are currently on grade 4, gangrenous toes, foot, everything, grade 5. And you have been sent to see those patients. What are you thinking about? What do you think would be our line of management for that patient? What do you think, what advice will you be giving that patient? What discussions do you want to start having with those patients with grade 5 or grade 4? Or who do you think at that moment should be involved in that particular situation? For patients with grade 4 and grade 5, you can pop your response in the chat box. Background noise. Please. Hello. Yeah, you can keep your. So as a patient on grade 4, grade 5, so what do we think from physio point of view? What conversations, what educations, or who are you involving for patients with grade 4 and grade 5? What are we thinking for this patient? Anyone ready to help us? Yeah, orthopedic. Somebody has written orthopedic. Yeah, go on, ma. Yeah, orthopedic surgeon, pediatrics, yeah, Peter Gabriel is saying, please, can we mute people that are having background noise? Yeah. So what are we thinking? Because this is, yeah, plastic, yeah, depending on where you work, okay? So what are grade 5, for instance, psychologists too, yeah, for people that are on grade 4, grade 5, let's say grade 4, grade 5, for instance now, what is like what are the likely things that may likely happen to them? Yeah. Okay, use of wheelchair. Okay, good. So what I would just say is, suppose I've been booked down to see this patient. I've gone to their bedside. They are on grade 4, grade 5. Yeah, occupational therapy. So the first thing I want to tell them, of course, grade 5 is very terrible. It's going to be very, very, very terrible. One thing I want to tell them, if they are mobile, they've been mobilizing around, they've been ambulating around with that leg. I want to first of all tell them it's high time we stop putting. I understand based on where we work, sometimes weight bearing might be decided by the doctor or something, but yeah, these are conversations we also want to, depending on where you work, these are conversations we want to have with the consultant or with the patient. That foot needs to be offloaded completely. When I say offloaded completely, means non-weight bearing on that leg at that particular moment. So if we are now saying non-weight bearing on that leg at that particular moment, what does that mean? So what that means is maybe we just get them wheelchair, we pivot them, or they do no lateral transfer to the chair to be sitting out or something. And again, somebody mentioned podiatrics. Yeah, you can also refer them to podiatrics. If there are some specialist shoe, footwear, depending on how bad. The fact that somebody, this is just clinical classification. The fact that somebody is on grade 5 does not mean, yeah, really well. But you want, even if you really want to get them to weight bear, there must be a very, very, very suitable offloading boot that will equally reduce the weight. Most of the time, I'm still going to show us the boot. Most of the time, evidence-based, most of the time, these people need some negative pressure to take off weight completely, to equally distribute weight completely on their leg. But usually, the likely outcome for this patient is they may likely need an amputation. That is the likely outcome. Because the risk is also there, systemic risk is also there. Don't forget, this might be infectious or something. The risk might also there. If you don't treat these things, if you don't treat it as urgent case, sometimes before you know, you start having aching high, you start having kidney issues, the wound starts spreading upward and something like that. So the likely things for this patient is may likely end up losing their leg. So suppose you are, so clinical reasoning wise, I go to their bedside. I am meeting them for the first time. I am seeing that this leg is really, really very terrible. We don't have any offloading at the moment. For the first thing I want to encourage them to do is reduce their weight bearing on that leg. I want to encourage non-weight bearing. And when I say non-weight bearing again, remember what we said yesterday? These are vascular patients, these are vascular issues. Do you now want to go and give them frame or give them crutches? And now give them crutches and now say that let's start open on the other leg. Don't forget, for somebody to have had this terrible wound on this right leg, they might also end up having issues, trouble with the other leg as well. Just like what we explained yesterday. So the safest option for them is, if you are keeping the other leg non-weight bearing, then that means they need to be transfer only. They need to be pivoting. They need to be doing lateral transfer. They might need to be doing banana board transfer. Evidence-based practice. This should be the standard. Not going down and get some frame problem and start and asking them to be hopping around. That will be detrimental for that patient, if that makes sense. So that, please, do we get that? Hello? Yeah, people have written a whole lot of things here. Amputation, hoist, if, yeah, please hoist the whole. Please, our organizer, can we mute people with these background noises? No open. Yeah, thank you very much. Yeah, thank you. So let's move to the next slide. So the next slide, different type of amputations you can find. let's say the wound has gone really terrible bad now, you've done everything. And again, the fact that you give somebody an offloading boot does not mean that the wound can still not break down and at the end of the day, not losing their leg. Just that sometimes what the boot does is, in some people, depending on how severe their issue is, in some people, the boot can still help them allow proper healing to happen. And in some people, the boot can also extend like the period of their progression into coming down to have this amputation. So it all depends. It depends. So different type of amputation you can find in the foot. You can find transplant amputation. Of course, toe amputation is there. You can find rail amputations. You can find heel debridement. Heel debridement is also there. So these are different type of amputation. And you can also find signs like we mentioned yesterday, ankle disarticulations. These are different type of amputations we can find for the foot. But before we get to this stage, we really need to be thinking about offloading. And if there is need for us to have that discussion, I know these are difficult conversations with people, but we really need to have that conversations with them, that we really need to keep this leg non-weight bearing, and we need to start arranging wheelchair transfer and everything. And again, when they are doing that non-weight bearing, it's a means of getting that foot, getting that leg, like not putting weight on it, the pressure damage that will happen with the weight bearing, the healing disruptions that will happen with the weight bearing. It's not there. So it's just a way of giving the foot some chance to try to see if they are likely to heal up or something. And again, somebody can have that stage 4, stage 5, something like that, and this medical team can decide to even do some, maybe the vascular supply to the leg, to the low leg is very poor. I've seen patients, they might just do stent, and they might just do bypass pipe. I'm still going to talk about bypass, maybe bypass surgery. They might do femoral popliteal bypass. They might put stents. They might do anything to improve vascular supply to the leg. But after the vascular supply, what do you still want to do? The foot is still there, so you need to give that foot some chance of healing. So keep that leg non-weight bearing in order to promote their independence at that particular moment. You don't want your patient to remain in bed. Of course, they're not going to remain in bed, in hospital bed for life. And again, by the time they go home as well, they're not going to remain. It's not great for patients to remain in bed. We want our people to be independent, to be moving around. But how will they move around? No hoping. They can't hope. We can't give them frame. We know that is wrong. So what do we want to do? We want to have that conversation about wheelchair with them, if that makes sense. All right, let's go straight to some offloading boots. Evidence-based. These are the recommended footwears, evidence-based, when it comes to vascular issues. I understand our situations. I completely understand the financial aspect to these things, but we need to learn what is great, and we need to see how we can, and of course, again, we can also come across patients that can avoid some of these things. Yeah, so I think it's really worth talking about some of these things for learning's sake, and hopefully we can also get to the point of getting our patient to be able to afford some of these things easily. So all right, so let's look at these things. Is there anyone we are familiar with? Or is there anyone you've seen before? Is there anyone you want to talk us through before I do my own stuff as well? Because I like to learn. Yeah. Is there any of them? Is there anyone here? Yeah. Oh, where's he gone? Sorry. Sorry. Yeah, I think it's more clearer now. Hello, is there anyone? So if you look at sorry, can we see the slide? I think I've put it on presentation mode now. Can we see it clearly, please? Hello?
Yes, we can see it clearly.
We can see it clearly.
All right, thank you very much. Yeah, so there are a lot of rubbish names. Some of these things are called, but the name is not as important as what they do. we don't have to be worried about their name, but of course I'll still tell us some of their name. So this is Pacopede. Why is it ped? If you look at these two, if you look at the second one here, this one is longer than this. I don't know why it is called ped actually, but this is called Pacopede. This is Vacocast. So this is the third one here. If you look at the length of this third one here, if you look at the length here, it's a bit shorter, like the length of the foot. It's a bit shorter compared to this first. So that means if somebody have got let's say they've got what do you call it now? Let's say they've got amputation to their metatarsal, like they've got transmet amputation. Amputation that involve their midfoot. Don't let us speak anatomy here. Amputation that involve their midfoot. Like their thumb is very, very short. Something like that. You are thinking about something, this last one. This is called camo rocker, camo body rocker. Their name is not as important as what they do. Now, these three of them here, they are all negative, they are all negative pressure boot. Negative pressure. If you pop it on the leg of a patient, what that boot will do is it's going to equally shift pressure. It's going to equally shift pressure, like it will equally distribute the pressure around. So the pressure will not be localized to one particular area. What are the patient group are we looking at? Of course, the third one here I've mentioned. Somebody have got mid-toe amputation, the mid-toe and the thing is gone, and the stomach is really very short. We are thinking about that third one. Now, the first two are very close. Their usage are very close. In fact, I would say the first two, let's say they do the same thing. You are looking at somebody have got any wound in the foot, anywhere. If they've got toe amputations, let's say 1, 2, second toe, any toes, if they've got toe amputation. So somebody have got heel ulcer, the wound in the heel. You can try this first. You can try that first. That makes sense. Now, the other one here, if you drop below the first one, the other one here, we are familiar with this one. This is something like our AFU. So this is called PRAFU. This is called PRAFU. Yeah, the name is not important at all. Now, if you look at this one here, okay, I think I've got another picture here. Let me show you another picture. If you look at this one here, please, can we see this slide, please?
Yes.
Okay, yeah. If you look at this first one here, what area of the body do you think this first one here will be offloading? Let's look at that first one. What area of the body do we think that will be offloading? Just have a look at that patient leg. What area of the body? Sorry. Oh, somebody was speaking. So what area of the body? The heel. Perfect. If you look at it, if you look at this thing now, this patient has equally, like they've equally weight be on the forefoot, the midfoot. But look at the heels. The heel here is what is offloaded here. Somebody have got heel ulcer. I'm also thinking about this. Or if I'm not thinking about this boot, I'm thinking about this first two here. Now, clinical reasoning kind of things. Yeah, clinical reasoning kind of things. Suppose you've got a patient. They are normally very active, they are independent, they've got good strength in their leg, but now they've chopped one of their toes, or they've got wound in their heel, or let's say they've got wound in their head, for instance. You know, somebody can think about these first two. Somebody can think about this first two, and somebody can also think about this one here. So what condition will make me give, or will make me say, yeah, is this first one or is this second one my patient will need, and not this one? Let me repeat the question. Suppose now we have said that we can use this first one, we can use any of these first two to offload heel wound, for instance, take the heel off. Now, if my patient has got a very, very good strength in their leg, what am I thinking about? I am thinking about this first two. Let me flip the question around. If you've got a patient with very poor strength in the lower leg, let's say what they do, let's say they've got stroke now, they have a very terrible, they have a very terrible stroke. If they need to walk, they are using walking stick, they need like 2, 3, 5 distance, they are tired already. They are very tired. So what they do normally is they just walk from their bedroom to the toilet normally with high energy requirement to do that mobility. They've fatigue easily. Do you think I can give those patients this first two? It might not be appropriate for them. You know why? Because this first two might likely to be heavy.
Hope you're not sleeping on it, sir. I'm not sleeping on it.
Hello? Hello? Are we getting these things? So what I'm trying... Background noise. So what I'm trying to pass across here is this. This one, the first one, the second one, we can use them to offload anywhere in the foot. You can use it to offload the heel. You can use it to offload the forefoot. You can use, but if you need to give this first two to your patient, think about patients that have good strength in their leg. Because this thing will come with some particular weight. It's going to add to the weight of the patient's leg. If they need to mobilize, do they have that good strength to be able to propel? You are not, you know, we are physio. We are not just, yeah, good, great. Why are they needing this thing in the first place? Because of the wound they've got. How about their mobility? How about their biomechanics? We are physio. We also need to put those things in the context. If that makes sense. But now, if somebody is coming with a poor mobility background, or they just need the boot to be able to transfer from the bed to the chair, then I am already thinking about this other one. And I'm thinking about this other one. If that makes sense. Please, can I get a response? Do we get that first part? Hello? Hello?
Yes, very well.
We got it.
Yeah, thank you very much. Thank you for that. Yeah, another thing is this. Suppose somebody has got foot deformity. When I say foot deformity, charcoal foot, just like the one I showed you the other time. The one I showed you the other time. Do you think now suppose I'm need to make this, suppose that patient that the picture we show ourselves the other time, suppose that patient, let's say they've also got heel wound, something like that. They've got heel wound, and I'm now thinking in my head, I want to make decision for them. Do you think the one here, this here boot will be more appropriate, or do you think the Prafo will be more appropriate? Which do you think will be more appropriate? From the picture I showed the other time, I can go back to it. Yeah. Yeah. Suppose this patient here, suppose this patient have also got heel wound, for instance. Let's say they've got heel wound. This patient have got heel wound, and I'm now thinking in my head, what boots or what footwear will be more appropriate for this patient? Do you think it's going to be this negative pressure boot, or it's going to be this what's it called? This Prafo? Which do you think will be much more appropriate for them? From biomechanical point of view, which do you think will be much more appropriate for them? Can I get a response? Hello? Yeah, somebody have popped something in the chat box. Let's see. Let's see. Yeah, negative pressure boots. Great, great. So we can also, why negative pressure boots? Why not Prafo here? Why not this one? Why the negative pressure boots? Yeah. I know these are things that are looking, yeah, I completely understand, but let's learn, yeah, maybe we can come across patients that can afford these things. We can at some point, things might start changing for us. We can start thinking about doing what we should be doing from financial part of things, but so can we get a response? You've got a patient, they've got charcoal foods or feet, whatever. You are now thinking about making decision for them. Do you think it's going to be negative pressure boot, or is going, and they've got heel ulcer with it, or is it going to look like that one like AFO? Which do we think is going to be appropriate for this? Of course, it's going to be negative pressure boot from biomechanical point of view. This one here is likely to support their ankle. If they need to mobilize, this is likely to support their ankle as opposed to the other one. The other one is just rigid structure, just take off the heel. It does not offer much more biomechanics. Yeah, I know this can also impact the hip when it comes to the hip, internal and external rotation, something like that. It can also impact that, but this does not really provide any stability to the foot compared to those negative pressure. These are just clinical reason kind of things. All right, let's move to the other one. If you look at this, okay, before I leave this negative pressure boot, suppose I've got a patient now. I've provided them what this negative pressure boot, cast, for instance, now. On the right, they've got heel ulcer on the right. So I gave them cast on the right. So what do you think will happen of course, what do you think will happen to the other leg? There's going to be a kind of height difference. I need to start thinking about, we need to do maybe heel raise on the other foot just to balance that. And if we can't do that, something we can just order online, get, what is this one here? This is just shoe raise or even up or level up or something. Just ask them to bring their own boot, pop this one underneath, and that will balance up the height. Those are the ones that is here. Those are the ones here. All right. So the other one here, I think I've got that one here. If you look at these two here, I don't know if these pictures are very feasible. So if you look at this picture here, these two pictures here, the last, these first two here on this last row. So if you look at this is just offloading the forefoot. Even from the picture, somebody can tell. If somebody have got forefoot wound or something, of course, the weight is going to be on the heel. And somebody have got heel ulcer also, somebody can also have this. But the question here is, if I'm providing any of these two to my patient, what are the risks associated? And do you think this thing can go, like I can just look at every patient and I can, they got heel wound, I give them this one. They get for wound ulcer, I give them this one. No, do you think this will be something you can just reason for every patient? What do we think? So what do we think are the risks associated with this one I'm touching with my cursor? Of course, these are Daco boots. These are Daco boots. This is just offloading the forefoot, and this one is offloading the heel here. So what do we think? Hello, are we still there? Yeah, PT Ibrahim, negative pressure boot because they are weight bearing on the medial malleolus. In addition to the ulcer, we make the weight bearing more. Yeah, good stuff. Thank you very much. Yeah. Hello. Sorry, are we still there?
Yes, sir.
All right. Thank you very much. So my question is, if you look at these Daco boots here, the ones here, so what do we think are the risks associated with, if I just look at patient and I'm giving this, any of them, so what do you think are the risks associated? All right, thank you very much. Yes, sir, yeah, that's it, thank you. So the risk for this one is, this patient will be weight bearing on the heel, fine. So how about the forefoot? So I cannot randomly give this one for every of my patient, because if you are not careful, that patient might end up falling. That would be physio related fall, something like that. So the patient might end up falling. So I want to, even if I want, we can still give it to some patient, but to vascular patient, it might not be 100% appropriate. Because don't forget, vascular patients, some of them are likely to be coming with diabetic neuropathy, cannot even feel very well. Some of them are having problem with perceptions, they are having problem with sensation and all of these things. So this might not likely be very, very appropriate. This might likely be maybe orthopedic shoes. People with orthopedic, maybe they've got fracture in the forefoot and they want to offload the forefoot. They want them to be putting weight. Of course, orthopedic patients, if they are young, they've normally got good balance, no severe comorbidities, they can follow instruction, no cognitive issues. Some of them can still use it. That does not mean that 100% you cannot also use it for vascular patients. You can still use it for vascular patients, but you need to really assess your patient with this. You need to be thinking about mobility aids. You need to be thinking about their cognition. You need to be thinking about how they can sequence their mobility. Because again, patient with this, if you look at the gait pattern, patient with this, they are likely to be doing step 2 transfer. Step 2, like I put my right foot forward, I stay there. I bring my left foot, stay there, like that, like step 2 transfer, if that makes sense. But Think about it. For vascular patients, do you think this can be 100% appropriate, given that some of them are coming from poor sensations, perceptions, and all of those things? So assess your patient and make your decision. That's what I'm going to say. But if you really need to offload the forefoot, think about vehicle cast, ear boot. If you need the heel and the patient is coming with limited mobility, you are thinking about Bravo, this one here. All right. Yeah, let's check another one there. So the other one I would like to talk about here is this one, this sander. Oh my God.
Come.
Is this sander here? So this sander is called Fecal Paso. Their name are not very important. But what does this sander do? This sander has it has an insole where you can just remove the pad. Let's say, for instance, now, please now.
Ngozi, please mute your mic.
So, thank you. So this is, like I was saying. Sorry, I need to go back. So if you look at this sander here, this sander is Fecal Paso. I don't know where those names are coming from. This sander is called Fecal Paso. So now, if you look at that sander, so that sander has this insole. This is the insole, yeah. Let's say somebody have got maybe second toe amputation, for instance. This is second toe amputation. It has a pad. I will just remove the pad. That there will be a space there. I don't know, I could have gotten the picture. Sorry about that. If you just remove the pad, then that space will be there. That empty space will be there. So that by the time your patient start putting weight on that leg, they will not be weight bearing on that particular part. There is something you can put on Google and check out how they do it and everything. So that's it. That's it. So this also can be used for if somebody have got maybe toe amputation, wounds in the toe, forefoot or something. You can also try this sander. You can try this sander as well. All right. So again, when it comes to choice, if you need to make the choice between this sander and that negative pressure, you also want to think about your patient. Think about the shape, the alignment of the foot. If somebody have got poor alignment of the foot, that sander may not be very appropriate for them. It might be something like negative pressure. If that makes sense. This is just clinical risk. There is no yes or no. That is why I said initially, it is your assessment, your understanding of what is going on that will decide whatever you want to be doing for your patient. You are looking at patient shape, the shape of their foot. You are looking at the wound they got. You are looking at the strength they've got in their leg. You are looking at the problem that led to that wound in the first place. If somebody have got, vascular problem, diabetes, or if somebody have got, if it is orthopedics now, let's say, yeah, they have a fracture, and the doctor are saying they can weight bear, and you are concerned. Physio now, we are concerned that if these people start putting weight on this leg, or the doctor have said, yeah, weight bear, full bearing weight bear, full weight bear them. And you have concern, and you've mentioned to them several times, I'm not comfortable with this, and they said, keep weight bearing them, no problem. Yeah, there are options we can give to patients. We can try some of these things. The issues is at the forefoot. Okay, how about if you put the weight on the heel? But remember again, so you need to put into consideration how old is that patient? Can they follow instruction? What is the strength? What is their baseline of mobility? What is their balance? What is their stability? Think about those things. Because again, if you give, let's say somebody have got orthopedic problem now, and I'm giving this forefoot for them. This one that upload the forefoot, this DACO, I upload the forefoot. And they are now weight bearing on the heel. If they end up falling and they have another fracture, it's going to be on that physio. So think about those things. As much as you want to help your patient, you are also thinking about a lot of factors. What is their background? What is their baseline of mobility? What is their cognition? So think about a lot of things before you make those decisions for them. The same thing for all of these things. You can have 2-3 of these things that are doing the same thing, but you need to check. You need to be checking, what is the shape? What is the alignment? If they've got poor alignment, if somebody has toe amputation, I can give negative pressure, I can give sander. I can give this sander for them, and I can give this one that take off the forefoot. But if they are coming from vascular point of view, like poor sensation, I will remove this one with forefoot. This is not part of my option. Now, if they got poor alignment of the foot, I might remove the sand and say, yeah, this one's the negative pressure will be the best for them. I don't know if that makes sense to somebody. There's another one too. This is called insole peg. This is a taco insole peg. This one. So it's just like the way you remove those pad from the Beko castle, the one this sander here, the same thing you do for this one. Somebody have got maybe very localized wound, diabetic wound, you just get something like this, just remove the pad and you give it to them and they start with bearing on it. These are what evidences have shown that it works for patients and we need to be looking at. Yeah, if in our facility we don't have some of these things, we don't have access to them, they are expensive, they are this, they are that. Yeah, of course, refer them to orthotics. If there is something they can give, the insole, bring the sole, and again, bring the sole of 1 foot more higher than the other. If the problem is at the heel, can we get them to put some weight on the 4 foot and take up the weight from the heel? If the problem is at the heel, can we take weight away from the heel and start putting weight on the 4 foot? This is what we want to also be communicating to the orthotics or P&O, or depending on what is obtainable where we work. And again, before you want to start, again, if you are also communicating that to the orthotics, have you also checked with your patient? What is their balance normally? How old is your patient? If you are saying, okay, let's elevate the heel and let's take off weight completely from the 4 foot, and this is a lady, this is a woman with a very poor balance issue. If they end up falling, they might likely end up in orthopedic care, which you don't want. So put a lot of things into consideration. Put a lot of things. So the rationale for these things is just to get us familiarized with some of those. There are a lot of these things. There are a lot of them. But I just extracted some of the common ones and brought them here. So there are a lot of them. There are a lot of things that we can actually do for our patients. All right, that's great. Let's move forward. Yeah, how about patients that are in bed, that they are bed bound? Patients that are bed bound, they are not moving in bed. Yeah, what do you want to do? You want to try to offload their heels. You can think about heel pillow. It does not necessarily have to be something like this. It can just be you popping pillows under their thigh, under their calf, just to bring up their heel. These are things we want to also be telling the nurses from day one. Patient is bedbound, they have terrible stroke in bed. We've been struggling to get them out of bed. We want to also be telling the nurse, of course, these are some of their own core area too, as well, checking skin, pressure area, skin, and everything. I'm not sure if we do that in Nigeria, but if our nurses are doing that, but this is something we also need to be telling them, checking pressure area, pressure damage, pressure area. We don't want patients to leave the hospital and start having pressure area, the infection will happen, and so we need to be feeding all of these things to our nursing staff. Generally speaking, they need to be checking this thing and they need to be documenting it. But let's just do our own bit. And so that's a consideration for footwear. Of course, the length, the width, the height, everything needs to be put in the consideration, like we have said. Further consideration before you think about any boots, any footwear for your patient, you of course do your holistic assessment. What are you looking at? Do that holistic assessment. What is their balance? What is their sensations? Is there any red flag? Are we looking at the case of DVT? All of those things you need to check before you make this. Even before you start speaking to P&O or orthotics or anyone, you need to check those things. Do your thorough assessment. Look at the shape of their leg. Look at the sensation. Look at the motor control. Look at the wound. If they've done X-ray, an X-ray, like I mentioned, X-ray might not even show anything. X-ray might tell you that everything is fine, but in the real sense, things might not be fine. So go with your clinical reasoning and make an appropriate. Sometimes in some places here, if they've done X-ray, even if I'm reading medical note and I'm saying that they've ordered X-ray, most times I will still look at the X-ray, but I don't really even get bothered with X-ray because I know within myself, X-ray is likely not to change anything. But again, let me say this again. If they put somebody for X-ray, because sometimes you might check the X-ray and they said they've got fracture somewhere, they've got a wound, but the bone has been involved now, and they now have a fracture. So what do you want to do? So this is not going to be you alone. So you also need to be speaking with the vascular doctor or whoever is leading in that your department, in that department or in that facility. You also need to be speaking with them. What will be their way here? What will be there? Because fracture has been involved now. They've got osteoporotic fracture, not osteoporotic. They've got osteomyelitic fracture now. So fracture has been involved. So you also need to be thinking about that. And again, sometimes what I've also seen in practice is, even most of them, they will say, yeah, I'm not worried, they are now on antibiotics, they've got osteoporotic, not osteoporotic, they've got fracture, and you physios, you can still weight bear them. Yeah, they have said you can still weight bear them, but this patient has wound. Do you still want to ask them to start putting weight directly on their wound? No, we still think about flooding. How can we offload? If it is ill, even if we don't have those devices we've shown ourselves, if it is ill, think about it. What can we do? Talk to orthotics, explain this thing to them. Explain to them, do a joint section, get them to come to see the patient together. Bring your clinical reasoning to table. Oh, yeah, is there anything we can do to shift the weight from the bottom of their foot to if it is lateral side, from that side to the other side, something like that. And if you can, till you guys come into conclusion, what do you want to say to your patient? You want to ask them for that moment, I think I would advise non-weight bearing. Don't put weight on that leg for that particular time. Because the risk, even though the doctor, the medical team might be saying, yeah, put weight. Yeah, they can weight bear. But you understand that this wound might likely get worse. It's going to distort the healing. And this is also something we also want to communicate with them. We also want to speak with them, bring clinical reason to table. These are my rationale. This is great. This is. This, if they start getting weight, it's going to distort their healings. It's going to make this thing worse. By the time you bring clinical reasoning to table, people are not interested in your anatomy or pathology or something. It's clinical reasons. Being able to look at the risk, weigh risk and benefit together. So that's how things go here. All right. The other part of this discussion I will quickly touch is about bypass surgeries. Of course, like I always say, I will sit down with anatomy and start touching anatomy and this thing. This is not why we are here. So this is just vascular supply to the lower leg. Some common procedures you can find to the leg when it comes to bypass. Somebody have got a poor supply to the leg. For instance, they got a wound in the leg, ulcer in the leg, and the blood supply is really, really very poor. You can find some of these bypass surgery. You can find femoral popliteal bypass, tibial popliteal bypass, fem bypass, fem-pop bypass. You find a lot of these things, all of these bypass. Now, but from physio point of view now, let's say, for instance, now you've gone to see a patient at the bedside. They've got any of these bypass. This thing does not change your line of treatment, honestly. But what should come to your head? Somebody have got what's it called? They've got incision from, let's say, from the groin now to their what's it called now? To their popliteal region, to the back of their knee. You want to think about, oh yeah, they've got an incision, they've got something to bridge the gap, like the poor vascular supply. And sometimes, let me say this, you might find by the time you are reading the operation note, they might say they remove a vein in the hand, in the leg, or maybe saphenous vein, or they remove a radial artery or something to do the bypass. Yeah, what do you want to do to that region of that body? You want to do some gentle range of motion, get them to move that part of the body. The same thing with the leg. Somebody that have got a bypass from the groin to the thigh, or from the groin to the back of their knee. What do you want to do? You want to ask them to do some gentle hip range of motion, knee range of motion, because you know there might be restriction because of pain, restriction because we know that there will be soft tissue reaction or not, and we want to start moving them. Yeah. What I've seen so far is, following all of these surgeries, there is no contraindication. Day one. What we do generally, we start seeing them, we start getting them to range of motion, see them out of bed. Just like, and I've said this thing many times, for every post-op patient, get this thing to be part of your practice. When you assume that, yeah, this patient, when they're having this procedure, they've had an anesthetic agent, they might be confused, they will be in pain. When I'm going to their bedside, I already have it in my back of my mind. I will do 480 with them. I will assess for their pain. I will ask them to take deep breathing and cough. I will assess their cough strength. Then I will look at the incision area. I will look at, is it clean? Is there any pulse or any distance? I will check. I will inspect. Then I will do active range of motion. I will ask them. This is day one. I won't be the one doing a passively for them. Ask them to do gentle range of motion. Assess for the strength. Assess for sensations. Because again, they've had an aesthetic agent, and all of these things are likely to assess their senses. These are just clinical. You have good reasons to be doing these things. Not like, every patient, range of, no. There might not be every time you even need to be checking that, but in this situation, you've got good reasons to be doing it. Good reason. And now, if I'm going to their best and they are now doing They are not even, they are just disoriented. They don't even know what is going on. I have reasons to now understand that, oh yeah, it could be because of the pain they are currently in. Now the pain is unsettled them. They are now very aggressive and this thing. It could be because of pain. It could be because of anesthetic agent they've had. It could be because of maybe they are dehydrated. It could be anything. You can now correlate. This is just, you are now correlating things together. So, all right. So what do I want to do? Just like I've been saying, day one, every surgery, if they are medically well, of course, I expect you could have checked their blood, everything. They are medically well, and you have checked the operative post-op instruction. There is nothing there, no red flag or anything. Commence and you've checked their post-op blood. Commence your rehab. Your goal should be getting them out of bed if they are able. If they are not able, just like we did for amputee yesterday, if they are not able, see them edge of bed. Begin to do, they've had bypass in their leg now. What are you doing? You're asking them to do gentle active range of motion. That's what we are doing. From there, we are standing and we are commencing mobility. That's how it goes. So these things are just named. It does not still change what we'll be doing with our patients. It's just the clinical reasoning of why are we doing certain things? Why are we doing certain things? Why are we, and we are documenting those things, if that makes sense. Case study. Before we come to case study, any questions so far? Any question, any reaction, anything? Is it making sense? Let's get feedback. Hello?
It is making sense.
All right, thank you very much. Thank you. Yeah, can I get a few more reactions?
Yes, sir. It's making sense.
All right, thank you very much. Thank you very much. Appreciate that. Yeah. So let's look at case study. So this is the first case. So the first case is on the amputations, the major amputation we had yesterday. So this is a live scenario. This is one of my people I've seen in the past. So let's see. Suppose this is our patient. You are reviewing a 45-year-old lady. They've been admitted to your ward. You are the senior physio on that ward. So they've got left above knee amputation due to complication from osteomyelitis and peripheral vascular disease. They've got right deep heel ulcer. Two things now. They have left above knee. On their right side, the good leg now, they now have heel ulcer there. He lives alone in house, and her daughter lives very close. So the past medical history is she's got AK high, acute kidney injury, she's got osteomyelitis, hypertension, she's diabetic, and she's got panic attack. So current issues from medical notes, yeah, you've got through the medical notes now. You see new onset of AF, atrial fibrillations, drowsiness, and reduced engagement on the ward. You also try to review the nursing notes now. So what you see from the nursing notes is they've been reducing medications. They've not been using medication. So what are your initial assessments? Your physio beats now. So what are your initial assessments? What are the objective measures and risk factors you will consider before commencing treatment? What are the likely patient barrier? What are the likely patient barrier to treatment and nursing care? Who can you involve? Like the patient has not been engaging on the ward. They are not eating, they are not drinking, they are not, they are refusing medications. So what are the likely barrier? Like why is this patient presenting? This is how we think. When you check nursing note, you see that patient is refusing care. They are not using medication. Then we need to be thinking, why is this patient doing this? Because if they are not using medication, so do you now want to go to their bedside? They are not eating, they are not doing anything, they are not engaging. The chance is there that they are likely going to do the same thing. And again, they are not using medication. This patient have got AF, they are not using medication. What does that mean? Okay. Then C, despite this, maybe at some point now, patient have started engaging now. Yeah. But the issue is they are now struggling with sitting and balance. Like after a while now, they started engaging. They are now using medication and everything. So, but the issue is they've got poor sitting balance. and the position of the storm in bed is not very good. What do you do? All right. And now at some point they are med fit. So what are your discharge planning? Don't forget this is acute hospital. Yeah. All right. So if you're answering any of them, you can open your mic. I'll give us some time to read and digest this question. If you also want to pop answers in the chat box, pop the answer in the chat box as well. There's no right or wrong. It's just clinical conversation. Yeah, go on. So who is helping us? So this is our patient. She's 45-year-old. On the left side, she has above knee. On the right side, she has heel ulcer. On the good leg, she has heel ulcer. And the problem is, at the moment, she has atrial fibrillation and she's very, very drowsy and she's not engaging. She's not using medication on the ward. So what are your initial assessments? Just picture the scenario. You go on the ward, patient is drowsy, she's not eating, she's not been using medication, she's 45-year-old. You look at her left leg, they've amputated it, the right leg, she has ulcer at the right leg. So what are you, and the medical notes you've read, they said the patient has atrial fibrillation. So what do you think? What do you think is going on, first of all? And how do you assess this lady? Are we just going to run away and say they are unwell, there is nothing physio can do, physio can do their trick, or we are magicians, we can just do something and get her stabilized and we discharge her? What do you think? Something will happen between the two. Is it that we run away, or we see that we do our magic, or we see that we do something? Yeah, definitely. We will be doing something. So what do we do? Yeah, who is helping us? Honestly, there is no right or wrong. It's just clinical reasonings. The goal of these things is just to it's just we sharing our knowledge. You know, I can learn from you, you learn from me. I build my clinical reasoning, you build your clinical reasoning. That's the goal. Yeah. Go ahead. Who is helping us? Or just anyone can just look at the question, connect things together. It might not even be the question now. Like, what can we see in these questions? Just connect things. Just look at anything and connect them. Honestly, in acute hospitals, these are some of the cases we'll find, like we just find plenty, multiple things intertwined together, and we need to really figure it out. Yeah. Who is helping?
Okay, I would like to chip in, like, since she's refusing medication, I will think of connecting maybe clinical psychologist.
Yeah.
Clinical psychologist to try to counsel her.
Okay.
So that she'll be able to take the medication.
Yeah.
And also accept the nursing care. Because if she's not accepting nursing care, I mean, the therapy may not be smooth for me to carry out physiotherapy for her. Yeah. So let her accept nursing care and start taking her medication. Of course, then I will now come in and start looking at how I will take care of her from my own point of view.
Yeah.
Thank you.
Yeah, thank you very much. Absolutely correct. And honestly speaking, that was part of the line of management for this lady. We've got reasons to revert to psychologists. she's coming from a background. That is why paying attention to patient past medical history is really very important and making sense of each and every of their past medical history. She's coming from panic attack background. She's got panic attack. That was her background. Now she's got amputations. Amputation, pain. Think about pain. Think about acceptance. Think about a lady that is coming from panic attack background. Now she's having huge pain in her leg. Now she's having struggling with acceptance. She might be struggling with acceptance. She might she might know all those kind of things. Now, what does that mean? That is enough alone. Leave every other thing out of this. That is enough alone to make this lady make her to be thinking, now it is our time, I need to give up. Now that might be enough for that lady to be disengaging on the world. And just like she said, thank you very much again, brilliant, very brilliant stuff. Just like she mentioned, if she's not using medication, she's not engaging with anyone, she's not even looking at her own daughter, she's not even communicating. Do you want to go? Yeah. Do you now think the chance that she will also do physio is just leave everything out first? The chance that she will also do physio. What do you do? You try. Of course, you can still go to their bedside, try your luck. It might be you. I've seen patients like that in the past. They don't want to see anybody. They don't want to see doctors. Don't forget, ideally, in an ideal world, it is not like the doctor is trying to treat and the patient is saying no. The doctor does not have right. The patient has capacity. The doctor does not have right. The patient can still make their own decision. And again, it is not left to the doctor to now start shouting or something. It's not done. What do? You will still be persuading them, bring your skill in and something. It could be you. I've seen situations like that where they will be reducing every care. People will just go there and you just talk to them, come to their level, you listen to them, impression, their concern, expectation, and everything. And you start managing those things. And they will now start engaging. Of course, it happens. It could be you going to their bedside and try those things first and try to speak to them and try to encourage them, use medication, try to check their what do you call it? Their coping, how they are coping at the moment. Try to check everything. What do you want to check? What do you their acceptance, everything. Try to talk to the daughter. Have you spoken to the daughter? As the daughter come around to see them on the ward? These are the way we are thinking. From compassionate point of view. As the daughter come to see them on the ward, have you spoken to the nurses? When they refuse medication with the nursing staff, when they refuse that medication, what did they say anything? What was their attitude? What was their behavior? You want to get those background from the nursing staff. Before you even go in, you want to first speak to the nursing staff. Even if you want to go in to encourage them, you want to speak to the nursing staff first of all. Or get those background. How did they behave? What was their attitude? Then you go to the bedside and try. And if they are not still complying with you, what do you want to do? Speak to the leading team, or you yourself, you can refer, depending on where you work, refer to the psychologist. Brilliant. Thank you very much. I appreciate that. Yeah, let's get a few more. It's just pick anything, connect them. That is the goal of this thing. It's not even the question. I'm not interested in the question. It's about we connecting 1, 2, 3, 4 things together in the sense of this thing. Yeah. Let me read the chat box. Yeah. PT Samuel, thank you. Is written, host please. Oh yeah, host please meet everyone. Yeah, thank you for that. Yeah. Let me read. Yeah, initial assessment, that's PT Ibrahim, thank you. It's written, initial assessment includes subjective already from the questions, the objective, risk factors, past medical histories, atrial fibrillation, there is need for counseling. Thank you for identifying that, very brilliant. You need counseling. It might not even be psychologist, it might be our imam, it might be pastor, it might be referent, based on their background. Speak with the daughter. Now this is coming from a panic attack point, like background. There will already, before coming to the hospital, there will be some coping strategy, there will be some line of management. This is how we think, we connect things together. Before she come to the hospital, there will be some line of management, something she's been doing. What does it like? What was her hobby? You can use those things to engage. We use those things a lot to engage patient on the board. Thank you for being able to identify that. And the daughter has to be involved. Brilliant. Involve the daughter. Brilliant stuff. Then monitor since he's close by. Yeah, the daughter needs to be involved. Yeah. Yeah. Great. Can we get a few more response? Connect these things together. Yeah. Thank you very much, Peter Ibrahim. Appreciate that. Yeah. Anything from our discussion so far? What else can you connect from this patient? What are red flag? If you need to treat, suppose you want to treat at the moment, is there any limitations? Or if you cannot treat them, what are those things that could be limiting you at the moment? Yeah. So, because believe me, in acute hospital, you will see a load of intertwined issues like this, and you need to sit down, figure it out, look at the medical note, the nursing note, everybody's note, formulate your clinical reasoning, go to their bedside, do your stuff with them, and if you cannot do your stuff, you still document. And if suppose you've been invited day one and you have gone to see this patient and you won't be able to do anything with them, what will you be putting in your notes? How will you justify that? Oh, this is the reason I won't be seeing this patient. You can pick that. Yeah, if whatever you'll be putting in your note, you can tell us. Let's learn. Yeah.
Okay, good
Physio.
evening.
Oh, good evening. Thank you for coming. Yeah.
Okay, there are various risk factors in this particular patient. For instance, the hypertension, the diabetes, and the fact that obviously she's refusing medication. And then another thing worth noting is the current issue of delayed onset atrial fibrillation, which is a risk factor for a stroke occurring. So already looking at it being like a vascular condition, we'll probably assess the color, the pulses, the sensation, proprioception. These are things that will obviously be affected in line with what she has. So now, what are we considering before we start treating this patient? Obviously, MDT has to be involved in this patient big time. Like you said, she might agree or listen to the physio, or she may not, but you would have to. You cannot say she did not agree if you did not go there. So you have to go there, and if she allowed to assess, she can assess and document your findings. If she declines the assessment, obviously you have to note that down, because you cannot be way back in your office and say she declined the assessment because of the other things documented by the other team. So whatever you see when you get there, you note that into consideration.
Yeah, thank you very much. Yeah, thank you. I really appreciate that. Yeah, she's able to link up some of this stuff with us. She mentioned that this patient is coming from background hypertension, diabetes mellitus, AK high. What that means is, even if I need to go to their bedside, I should be checking my bloods. I should be checking my orbs before going to their bedside. I won't just, oh yeah, physios have been invited. I just read their medical notes. I ignore the blood, everything they've done, and I'm going to their bedside. Even if this lady is engaging, and you just ignore, and you just go to their bedside. You are a technician. Basically, you are a technician. You're not doing well. Because again, remember, this patient have had above knee amputation, major blood and major vascular surgery. This patient have lost their limb, they've lost their leg. Their potentially, this patient could have lost some blood, their HB, their red blood cell might be low. We want to check their post-op HB. Have you checked that? You are checking their potassium, you are checking their iron now, their plate, everything you need to check. What are those things? What else do you check? You check their hopes, their vitals. You look at the trend, what nurses has been doing, they've been doing on the ward. You look at the trend. What is the trend of the blood pressure? What is the trend? What is the trend of the heart rate? They mentioned to you that they've got atrial fibrillation. Thank you for being able to identify that. Atrial fibrillation is a big red flag. Their heart rate might be 180 at the moment. Their heart rate might be 120, 130, 135. Do you want to go there? Even if she's engaging, remove the engagement part. Now, let's say she's engaging normally on the wall and the heart rate is 130. Do you want to go to their bedside and you start mobilizing them? No, heart rate of 130 is a big one for you. That starting heart rate is a big one. By the time you mobilize them from, let's say, You don't forget your goal day one is if they are able, get them out. Let's say now, or I'm even doing exercises in bed with them. What is likely to happen to the athlete? You are now further straining their heart. That is what that means. You are further straining their heart. You are further putting challenging their heart. You are challenging their heart with your mobility, with your exercises. So their heart rate from that 130 or from that 125 can jump to 160, 170, 170, 130. No. Do you think that is great for your patient? What are the risks? This is how we think when we are, like I keep saying, clinical reasoning. So now, what are the risks? Why am I saying if I want to speak to the doctor, this is just clinical reasoning? Like I said, nobody is interested in pathology. It's not that. That is not physio. And anatomy is just one of those things. It's not physio. It's not clinical reasoning. It's not physio. And physio is physio. Now, if I want to speak to the doctor on the ward, and the doctor has said to me, "Oh, physio, we have injected you. Have you done, or you've not done something, or have you done something?" What do I want to say? I can't. From now, I've mentioned to them that AF. I'm just worried with AF. What if the person said, let's say the person asked me, the doctor asked me, why? What will I be saying? What are the risks associated with AF? Somebody, if you can pop that in the chat box, I will appreciate that. What are the risks associated with AF? Why am I so worried with that AF? The heart rate, the blood pressure, the diabetes mellitus, their hypertension is something I can easily look at their ops, the vitals nurses have done. I might not be too worried from there. I might not be too worried about that one. What their DM is, once their glucose level is okay, I'm okay. If the blood, anything greater than, remember we have discussed ops, I have explained some of these things. If their blood glucose is more than 4, I think I'm okay. And if it's not as like anything between 4 and 15, 4 and 10, I'm fine. If it's 8, I'm fine. I'm doing my stuff. I'm not worried with their background of diabetes mellitus. I'm not worried about that thing anymore. Like in terms of seeing them, in terms of treatment, if their blood pressure is okay, I'm fine. That's it. I've cleared those parts. But the part I'm concerned about now is now AF. And the question I'm asking is, why are we concerned about AF? What are the risks associated with it? Let me read the chat box. Yeah, people have written a lot of things: stroke, heart failure. Yeah. So what are the risks? Thank you, atrial fibrillation. Yeah, what are the risks associated with AF? The big risk. Let me leave that to you guys first of all. Yeah, what do you think? Big risk, because this is acute hospital is a very dynamic. It is clinically loaded. You need to be seen. If you really want to be seeing patients that are acutely unwell, you want to be working in those high dependency areas that are very tight, that you need good clinical research to be able to work well, to fit in well for the MDT. Honestly, we need that great clinical reasoning. Because sometimes they will call you, physio, come and say, it is you that will look at it and say, no, I'm saying, no, I'm not saying, because and you justify why you are not doing that certain things. So why are we worried about AF? Why am I worried about heart rate of 120, 130 at the starting heart rate at this moment, like at that moment of my patient care? Why am I worried? Guys, let's respond. Let's make this thing interesting. Yeah, let me check. Yeah, atrial fibrillation, get fatigue easily. Yeah, of course. Patients that the heart rate is jumping up and down, of course. They might even be having work of breathing at the moment. They might be struggling. I know some of them might even be short of breath. Some of them might be short of breath. Some of them might be looking fatigued. Thank you for that. Yeah, they might be distressed at the moment. Yeah. But what is my big worry for this patient? Big worry, just 1 or 2. Yeah, people have written dizziness, faint, thank you, PTUG, PT Ibrahim, hypertension, bradycardia. Yeah.
The sugar level too. I'll be concerned about the sugar level.
Sugar level should
like diabetes.
Yeah, of course, you should be concerned with the sugar level. Yeah, you need to ensure the sugar level is optimized. Thank you for that. For the AF, the big worry, your biggest worry about this patient is blood clot. If somebody has got AF, how can I explain these things? AF is just like, if you imagine a worm, earthworm, or is it earthworm? Yeah, like the patient has got like something like, imagine a bag of earthworm. Like I just come. Imagine, no, don't let us use that. Imagine you've got the heart supposed to be contracting this way, but now they've got here, it's not contracting irregularly. The contractility is not regular. What does that mean? Somebody blood clot is not too far from your patient. What does that mean? You know what the implication of that? Somebody have written stroke, somebody have written cardiac infarction, all of these things. You need to be worried. That's a big red flag. So if I'm speaking with the doctor, I'll cross my leg and say, yeah, I'm not going to see because of this, because of that. So get monitor is their duty now. So they monitor the heart rate, check if the heart rate is optimal, then I can see. Sometimes you can even ask them, yeah, are you people happy to document the target heart rate? Get them to document the target heart rate. That's how we think. If that makes sense. You are worried. And again, from fatigue point of view, just like somebody have written, I think PTUD, yeah, that's very brilliant. They will be very, very fatigued. Somebody with heart rate, imagine you are running, for instance, and you got your heart rate to be at that range, like one something, one big one something. Imagine their work of breathing will be high at the moment. You might not be able to get anything better from that patient. They might be short of breath about those things. And again, from drug point of view, this is acute hospital. From drug point of view, let's say now I'm going in. There's somebody I mentioned to me, they got here. What should I be checking from there? I need to be checking. They should be on anticoagulants. You need to go and be checking those things.
DVT.
You need to check before you go. You need to be checking those things before you go in as well. So now, so connecting all of these things before you go here now, we know reasons why we need to be checking their HB, their red blood cell. They have big surgery, they might have lost blood. Some of them might even be on transfusion, blood transfusion, day one after the surgery. Sometimes when you read the medical note, they might say transfuse when HB is less than this, when HB is less than that. Some of them might even be on blood transfusion. You are checking those things. You know reasons why you are checking those things. Because sometimes some of these people, based on Nigeria situation, sometimes you might even be checking, and the doctor will ask you why, or they've not done the post-op blood, operative blood, post-op blood, and they've not done it. And before you go in, it is also our responsibility to ask them. Oh, I think yeah, we are aware this patient have had this surgery, this procedure. Yeah, when are we looking at getting their post-operative blood? Have we requested from their blood? A doctor can just look at you, one junior doctor that does not even know what he's doing yet. He's still learning. Can just look at them and say, what do you want to use blood to do? I know it is something our people can ask in Nigeria. We can then say to them that, see, this patient have had a major amputations. They might have lost blood. We need to check their blood. We need to ensure that their HB, their red blood cell, their potassium are optimal before I go in to see them. That's a good clinical reasoning. No, that's enough. That's enough. We don't blame people. Sometimes you don't. It might be from learning point of view, like they don't even know why you are doing something, which is normal. They are not trained to be a physio, which is normal. Sometimes we assume they know everything, but these people are not trained to be. We are also not trained to be doctors. But we only need to know some medical things that are related to our stuff, just like this one. Heart rate is related to this patient. If I need to be doing stuff with them, I need to do it. So again, we have cleared the issue of blood. We have cleared the issue of herbs. You know reason why you need to be checking the herbs. You are from the panic attack, the presentations of the word or anything, you know who you are working with. All right. Now, suppose now everything is now okay. This patient HF has improved. This patient has now started engaging. They have now started eating and drinking. Everything is okay now. What will be your? That means tentatively in the day one, if I go to their bedside, it is very unlikely that I may not be able to get anything out of that patient. I may not be able to do anything with that heart rate. I may not be able to do anything. They are not even engaging. So the luck I would just want to try with them. I will go to their bedside. Compassion first. Ask them pain, how they are feeling. Is there anything? I also know that this patient might be struggling with pain. I want to ask them about pain, pump sensation, 480, all those kind of things.
Your tab.
Please, guys, please. So these are some of those things I want to be asking them. All right. I want to ask them 480, complete social history. I want to call the daughter. I want to complete. These are my initial assessment. I want to call the daughter, complete comprehensive, very, very comprehensive social history. Very comprehensive. Like I said yesterday, get information about their toilet, this is amputation we are talking. Things will change. Oh my God. Titi Olatunde, please, can we? All right. So get information about their toilet, about their bedroom, about their bathroom, everything, information, where she lived. Now that the question has said she lives alone, you need this social history is not enough. We need everything because things will change. Things will be changing from this lady. All right. So then after that, I can also give her form, like I mentioned form yesterday, like all those forms, get the height of that. Then I can call the daughter and start talking about wheelchair stuff. She's going to need a wheelchair in the long run. If she's able, anyway, we don't. Then background, where is he coming from? How does he mobilize? How does he work? Our day-to-day activity, how does he complete? Social history must be completed. So after all of those things, what else? Now, let's say of course, I need the heart rate to be able to be stable and everything. Then I will commence my rehab. I will start getting them out, feed them edge of bed, assess their sitting balance. This question I've also said that this patient is struggling with sitting balance. Even before I go into that, once they start engaging, you will still do your phantom assessment, observe their edema, their storm, their edema, range of motion, sensation, everything they've got in that storm, in the other leg. Don't forget about the foot of the other leg. The foot of the other leg have got right heel ulcer. Do you want to ignore that? Or now that they even say they have right heel ulcer, even if this patient is able, do you want to go and bring frame for them? Do you want to give them elbow crutches or auxiliary or whatever you are using in the hospital and ask them to start hopping around? Say, yeah, 45 years. You're likely to do it now. You are just 45. You can still use frame now. That is a very poor clinical review. Somebody have done a surgery, vascular surgery, they found heel ulcer on the other leg. You want to have them to start hopping. That won't go well. All right. So assess those things. So now the other question that says, so your barrier to treating this patient, your barriers are this patient is not engaging on the ward, they are refusing nursing care, they are refusing every care, the atrial fibrillations. In fact, my greatest barrier in this patient is that AF. That AF needs to be handled by the medical team before I go in to see them. If that makes sense. So all right. So what are you saying to the nursing? No, that's done. Then in terms of they are struggling with sitting balance. What are their reasons for poor sitting balance? Like we said yesterday, somebody can struggle with poor sitting balance. It might be proprioception. It might be struggling with alignment. It might be now they've lost their core strength. Now they are in bed for a longer period of time. They've lost the condition. It might be because they might be having struggle with their pain. Phantom pain, phantom sensation. Remember those things I told you guys yesterday, telescoping effect, all those things. Frozen limb, it might be any of those things. It might be acceptance, it might even be confusion. It might be agitating. Pain can make her agitated. Anesthetic agents can make her, anything can make her agitated on the ward. It might be emotion, it might be acceptance, it might be anything. So reason out what could be impacting that lady. Reason out what could be impacting that patient, and now start approaching those things. If it is pain, have you asked her to do desensitization massage? Have you tried different surfaces, different things like I mentioned yesterday? Have you tried range of motion, actively or passively, whatever? Have you asked for, pain is not, like I keep saying this thing, pain in acute hospital is not just physio pain, like we do in that patient. No, you don't have anything. Have you asked them for pain medications? The medical team, the nursing staff, they can support with pregabalin, gabapentin, and all of those things.
No, my baby. Oh, sorry.
Pity Fatola, please mute your mic. Pity Fatola.
Nathan. Nathan.
How do we get him? All right. So so let's put those things into consideration. So they need pain medication from the medical team. They need support. They need support from the daughter. They need support from the daughter, regular visit to improve their mood, to improve their acceptance level or something. And again, it might be psychologists, our previous coping strategies, those things need to be brought down to the hospital. Like we need to get big information about those things and start using those things to engage out in the world. So in terms of progression, how do you progress her? You establish transfer method. This is low lateral pivoting, banana board, hoist transfer, whatever you want to use. And again, for that right heel loss, I'm repeating again, you need an offloading boot. You need an offloading boot. You need those negative pressure, or depending, you might need Prafo, you might, depending on where you liaise with orthotics, P&O, get offloading boot for that.
Later, come and sleep.
Medically fit, do we want to discharge this lady? How do we plan discharge? Yeah. So we want, before we discharge this lady, we want to ensure, do we have established transfer method at the moment? Is it consistent with that transfer method? And again, some people, it might be difficult. It's not everybody that will be able to do low lateral pivot transfer. If we've not been able to establish any transfer method and they are saying it's med fit, of course, you still leave the hospital. You might leave the hospital, okay, in bed bound. Then we can arrange follow-up from there. And we continue with our exercises, everything, getting us stronger, progress the sitting balance, progress transfer method. But let's say at the level of the hospital, we are able to progress our sitting balance, to progress our transfer method. She has a good transfer method. Then self-propelling wheelchair around, get her to be very strong. We do exercises. There is a part of the question that says she's struggling with storm positioning. That might be because of the phantom pain. It might be because of maybe pain now. She's now putting the leg in flexion position or something. Don't forget this is above knee. You don't want the leg to be sitting in flexion contractor position, something like that. At one point, when she's able, when she has what's it called, less attachment, we can try her in prone position just to stretch that hip flexion rather. These are some of those things we can put in. But before you leave this lady, before you discharge her from physio point of view, you want her to have mobility equipment, good transfer method, ensure that the home is okay for her, like the adaptive equipment is okay. Does he need any toileting device? Put everything in the consideration. Look at her ADL and ensure that everything is okay for her before you finally discharge this lady. I think that answers. Any question on that? Any question on that? There is this other question here, but I won't take this one. I think we can discuss this one.
Oh yeah, come madam, bring the tablet.
I think we can discuss that one on the page. So amputee rehabilitation, and again, part of your initial assessment for this lady could also be that. On there might be question, even the daughter might be asking you, when is our mom likely to get a leg? What is the chance of our mom getting a leg? You can also do
sorry.
Look at that.
You are disturbing your own stress.
Look at our previous abilities. Look at our current ability. Look at our current ability and use those things to decide and if it's suitable, then in our outpatient, this thing we can start putting out we can start progressing now from there. And but that is not a criteria to keep her in the hospital. The major criteria physio-wise for this lady when it comes to discharge is establishing that she has a good transfer method. She has a good what to return to. So that is that about that, if that makes sense. Yeah, can I get questions? I'm going to hand the teaching here. The other question is something we can discuss on the page. A lot of disturbance today, but any questions, any contributions, any clarification, anything you like to ask or you like to share with us? Hello, are we still there? Oh, am I just speaking? Hello?
Yes, sir.
Right. Thank you very much. Thank you very much. Yeah. Any question? Anything? Okay. What is MFF? Yeah, that's medically fit for discharge. Like the patient is set to leave the hospital. That's what it means. Medically fit for discharge. Oh, there's another question there. What is OM? OM is osteomyelitis. I'm sorry for my abbreviations. OM is osteomyelitis. The other one is peripheral vascular disease. So the point in this question is just to highlight that in acute hospital, there is no direct way to seeing patients. It is all about your clinical reasonings. It is all about the way you can use the NDT. It is all about looking critically about the patient notes, speak to your seniors, get people opinions, discuss with colleagues, speak with the family, speak with the patient themselves, speak with the nurses at the bedside, speak with the medical team. Honestly, you cannot be a successful physio in acute hospital without a good MDT. And again, they cannot also work well without, because in this situation here, this patient is going to need physios, but it's going to need physio. It's not medical domain. Of course, she needs medical input, but she's going to need physio as well. So what is AF? AF is atrial fibrillation. Atrial fibrillation. That's what it means. So that's it about this question. So the other questions there, so we can discuss those ones on the page. So I think this is okay for today. It's a big clinical questions. So I would just like us to pay attention to some of these questions, and yeah, just to build our clinical reasonings. And yeah, it does not see me again in acute hospital, everything needs to be this clumsy. Sometimes you can find things very easy, just go to my bedside, do your stuff and run away, which is good. But sometimes you can also find things being very, very clumsy. Like you really need that sound clinical reasonings to arrive at certain decision for patients. So that's just the rationale for bringing some of these questions here. So any other question or any patient scenario you like to share or anything? Or so far, anything you like to ask about vascular? Because next time we return back to cardiothoracic, by the grace of God, we're going to talk about cardiothoracic surgeries, what we'll be doing with them, all those kind of things. So this is vascular. Any other question? So I'll be sending the slide over so that we can have a look. And all right, so in the absence of question, I'd like to say thank you very much, everyone. Thank you for making today a success. Thank you, I really appreciate us. Thanks for our time. So we'll catch up again in our next session by the grace of God. All right, so enjoy the rest of your week today. All right, next time.
Thank you very much. God bless you in Jesus' name.
Thank you, sir. Thank you, sir.
Thank you, sir. Results.